What are the most significant shifts that you see in dental education occurring over the next 7 to 10 years?
I just think we're moving clearly to large practices. So now as we look around the country, it's really headed, as you've said, towards 65% overall, women.
Because the audience really wants to know this. What are the secrets to get into dental school?
I guess it's for the better. I guess in many ways, that's why if there's more competition, the better, which will improve the quality of care, the quality of...
I'm particularly intrigued by the work-life integration because...
Welcome to the Pulp Dental Podcast, where we take a deep dive into all things dentistry and non-dentistry. I'm joined today with my co-hosts, Dr. Koch and Dr. Parsa Shahidi. Annie and Parsa, we have a very special guest today.
That we do. We're really excited about having Dr. Rick Valachovic here with us today on the Pulp Podcast. He's the professor and executive director at the Center for Oral Health Policy and Management at the great New York University College of Dentistry. He began his career on the faculty of Harvard School of Dental Medicine and served for 22 years as the president and CEO of the American Dental Education Association, which is something we're all very, very fond of and love. He received his DMD degree from the University of Connecticut, and then he completed his advanced education programs in pediatrics and dental public health at Harvard School of Dental Medicine, the Children's Hospital Medical Center here in Boston, and the Harvard School for Public Health. His current research at NYU focuses on leadership development, workforce issues, and access to care. He serves with Dr. Nasseh on the Ginobili Special Advisory Group at Harvard School of Dental Medicine. And among other things, he is an incredible leader, and we're grateful to have you here today.
Thank you.
Welcome.
Thank you.
Well, having introduced Rick properly, Parsa, Rick, let me ask you kind of the first question, maybe to get the ball rolling. And I think I'm coming from a perspective. I've been in dentistry more than 50 years, as you know. And so I when Ali asked me about joining the podcast, just like yourself, I've had a number of opportunities through the years, but I've never been so inclined. But the thing that makes this really interesting to me, Rick, is that it's 3 generations. As you know, Ali was one of my residents at Harvard, and now we've got Parsa. And this is really terrific because you have, 2 bright young men there looking things at a very different set of spectacles, looking through different spectacles than I see things. But I think one thing that can unite all of us is the following question. You and I have seen many, many shifts in dental education through our 50 years. What do you see what are the most significant shifts that you see in dental education occurring over the next 7 to 10 years?
Thanks, Annie. So I think that what we're going to be seeing is the impact of this new generation and the changes that they bring to not just practice, but to life in general. And so, we talked about over the past 20 years or so, the transition from baby boomers and the introduction of digital, excellence that maybe we didn't have. But I think that what this next generation is going to bring, they're digital natives. They're comfortable with emerging technology.
Yes.
And that's where things are going to happen. Right. Look at what's just happened in the last 2 years around the introduction of artificial intelligence and how dramatically it has changed things. It has created jobs and it's taken jobs away. We're instituting 3 Mile Island to provide enough electricity for a data center in central Pennsylvania. The technology issues are going to just explode.
Right.
And this next generation is ready for it. And I think that as we now are accumulating what has been the development of digital dentistry, the use of scanners, the use of 3D printing, the use of CBCT, the use of same day crown preparation and placement, whatever. That now with AI, we're going to be able to put all of that together, get better diagnosis, earlier diagnosis, much more minimally invasive procedures. And I think that this next generation is just ready for that. They're more attuned to work-life integration, things that many of us, it didn't work. You either had your work or you had your life. And I think that this next generation is able to have that integration, and that's why DSOs are going to grow, and with the resources that the DSOs have, as opposed to these small boutique practices that we've had, that the integration of technology is just going to be what's going to drive everything.
I'm particularly intrigued by the work-life integration because I'm a person who I think endodontics, particularly for women, could be one of the greatest specialties in either medicine or dentistry. But one of the things also, and it was really one time brought up at a board meeting at a school that I'm a board member of, was about the gender equality, and that in some of the dental schools now is the ratio is more than 5-to-1 female to male students. And
Yeah.
when I went to dental school in the 70s, this was at Penn, we had 152 students in the class with all the capitation in those years. We only had 9 women. So that was extremely skewed to the male student. Now it's kind of going to the other way. Do you see any issues with gender equality in terms of dental applicants and dental acceptances?
Well, I think that what we're seeing. So when I was at ADIA, that's where the Common Application Service had sets, right? And so it was 2016 that we saw the change that women became
Yes.
majority applicants
Yeah.
and majority acceptances. So now, as we look around the country, it's really headed, as you said, towards 65% overall,
Right.
women. And in the work that I do here at NYU, where we have 65% women in the class, they do bring a different perspective to everything. And then they're bringing a different perspective to practice as well.
Yes.
And not just that they're forced in many situations to take care of family issues more than men have. But I think there's a balance happening now as this next generation is starting to have families. A balance of, it's not just the responsibility dominated on for the woman is not as it was when we were getting going. So I think that it is, and not only are they less likely to get into an equity position in a practice, so they're DSOs and large group practices work better for them, but they're also more likely to take care of Medicaid patients. They're more likely to provide care in situations where the patient may need financial resources or may need other kinds of approaches for their disabilities. And so I think that women are bringing a whole new dimension to dental education and to dental practice, and that's all for the good.
Absolutely. Ali and Parsa, you better get a question in because I could speak with you for 2 hours nonstop.
No, of course, we're just enjoying. It's great information. So, Rick, what in terms of what Annie mentioned in terms of some of the shifts in the gender and potential lifestyle choices and things that people may end up making, is that then all feel like it's driving things to a different economic models? Is the future of the economic models that are used in dentistry going to evolve, and how's it going to evolve regarding, for example, the effect of student debt, the use of the DSOs? Are more women going to be working for DSOs possibly, or the demographic changes as a whole? And how is all of that going to affect just the overall financial picture of dentistry?
I think that the practices that we've traditionally thought of, and it was into the 1990s. It's still 92% of practices in the United States were 1 or 2 person practices, right? And it was those, and then the dentist devoting 35% of his or her time to administrative issues. I think that as we move towards the DSOs and large group practices that are not necessarily DSO related, but these large group practices, multi-site, multi-practitioner, large staff, that they're better able to work with insurance companies to maximize reimbursement through very specific standard operating procedure procedures that maybe a small practice isn't able to do. So I think that it's clear we're moving away from the small boutique practices many of them only open 4 days a week for only 8 hours. Think of the capacity of all of that equipment just sitting there that the large group practices, DSOs, are able to take advantage of and be more profitable. And given the types of practice approaches that this younger generation is looking for. And as we talk about work-life balance, or whatever words you want to use, I have to tell you that as I go around to meetings, and I was just at a meeting in Dubai earlier, ADEC, what I kept hearing was dentists wanted continuing education about meditation, about yoga, about the kinds of, at the conference in the future, that really dealing not just with work-life balance, but really finding ways to enhance their lives through the use of these kinds of things. So, I just think we're moving clearly to large practices. The 1 or 2 person private practice will go away as years of my generation goes away. And we're going to be replaced by a very different
healthcare model.
A culture. Yeah.
From what I gather, Eric, do you think that the overall this kind of corporatization of the process would be by and large positive? Is that what your view is?
I think done right, and there are DSOs and large group practices who are doing it right with the right incentive. But we've got to go through this transition of moving away from these small practices to the large practices, providing the incentives to dentists and staff to be productive in a way that maybe didn't necessarily have to happen before. And remember that when we talk about corporatization, we got to remember that I think there are very few practices in the United States, no matter how small they are, that don't have LLC or PC after them. Right. I mean, everything is really corporatized in a way already. It's just I think that, yes, that for dentistry as opposed to medicine, I think dentistry has an opportunity to really be successful in these DSOs and large practices as we move forward.
Dr. Valachovic, I appreciate it because I think you bring a lot of expertise and unique insight into this conversation. But I'd love to push back or ask you a question here. I think the big debate has been for these DSOs has been, do the providers, do the doctors lose autonomy and decision-making power? And I have to say, speaking to colleagues through the job search process, interviewing with these different, whether that's DSOs or private practices, the allure of the private practice, model is that you get more decision-making power. You probably have more control of your schedule and your treatment protocol, your treatment plans.
Yeah.
What would you say to people who would say, I lose a lot of autonomy working for a big DSO as a provider?
I would say that you do lose some autonomy, but it depends on the DSO. It depends on the practice that you're joining, and you need to go into that practice, either contractually or otherwise, that you maintain whatever autonomy you can. Now, if you're coming into a practice, they're going to have certain policies and procedures, but they don't necessarily take away that autonomy. Yes, there are some bad apples out there. Everyone agrees to that. Mm-hmm. But if you look at the work that the Association of Dental Support Organizations, ADSO, has done, they're really trying to bring an ethical perspective to this that maintains the independence of the dentist, but provides for some standardization so that as patients come through, it becomes more efficient. And therefore, the productivity enhances, and as a consequence, a dentist can be successful financially as well.
And
That's
then,
how I see it.
and Parsa, let me add something because Rick,
Sure.
before I mentioned when we were talking about kind of like the life integration thing, work-life integration, and the gender issue, where he mentioned that it's like 65% women, but they're generally not looking for be equity owners that own their own corner practice. So the fact that now we've had this change in terms of the gender distribution, we have more women. Unlike most guys, gentlemen, women have a life or want to have a life, okay, and have a family. So the idea that they can have a lot of that kind of corporate business stuff that you have when you're running any small business, be it dental or otherwise, they're not doing that. They can concentrate in
Right.
other ways. So the graduation of so many female dentists, Rick, I think is a perfect match with the increase in DSOs.
Yeah. And he made a great point. But let me just remind us of something. So, Annie, when you and I graduated
Right.
from dental school, there were 6,300 graduates, right? At the late 70s, early 6,300 graduates. So then in the 80s and early 90s, 7 dental schools closed and another 7 almost closed. The ones that closed were private. The ones that didn't close were public. So that by 1990, just 10 years later, we went from 6,300 graduates down to 3,900. 6,300 down to 3,900. Now we've opened, almost 20 new schools in which, but we're only graduating this year 7,000. We're only graduating 7,000 new dentists this year. So the when you just look at supply and demand, the population when you and I graduated was 240 million. It's now 340 million.
Right.
And we have only the same number of dental graduates.
The access to care issue for me is a big thing. We'll talk about that a little bit later. But one of the things, just talking here in terms of the graduates, are you including advanced standing graduates as well in that number?
Yeah.
Wow.
Yeah. So there's whatever when you include. I mean, there's like 7,300 new licenses.
Right. And I have another question because I've never quite understood this. I've heard people, and these are the dentists, the dental people in the dental world, talking about for-profit dental schools. I mean, what is the difference between a quote regular dental school and a quote for-profit dental school? What's the difference?
So there is a for-profit dental school in California, and so they have investors that they have to return to, right? And whether or not those investors were looking just for financial gain or were willing to socially invest in this kind of thing. But all the others are not for profit, and are and are subject to the rules. And a third of them are state supported. So that has it. So I think there is this perception out there that some of these new schools are for profit. They're not. They're all, except for one. They're all not for profit.
Oh, okay, yeah. Right.
But they don't have postdoc advanced education programs necessarily. They're not doing a lot of research.
Oh.
They're really just putting out practitioners for the area.
I think that's really a great answer because you hear people talk about for-profit dental schools with an S, and you're saying there's like one. It's a big difference.
Yeah.
Thank you.
Yeah.
But Rick, there are a few coming up as well, the few new programs and new dental schools, right? Aren't there?
Yes. There's I think it's like there's 74 CODA approved dental schools in the United States, and there's another 7 that universities that have plans for dental schools, most of which have founding deans.
I had a quick question for you, Rick. Obviously, you're president emeritus of ADIA, Dr. Valachovic, and I was looking through some of the data that ADIA published. And in the year 2000, the mean academic average DAT score, the dental admission test, because we have a lot of viewers who are, already in this profession, but looking to get into this profession. And I think this is going to be really interesting for all those people and all those folks. So in the year 2000, the mean DAT score was 17.8 out of 30, for those who don't know. And in 2024 is 19.3. The average GPA in the year 2000 was 3.2. for accepted applicants. And in 2024, it was 3.53. The average GPA for first year enrolled students in dental school in 2000 was 3.35. 2024 was 3.67. So obviously a large gain, in terms of performance across DAT and GPA scores. So this might be a tough question, but I think the audience really wants to know, based on this data, do you think it's too difficult, or do you think it's not difficult enough to be accepted nowadays into dental school, given this data we have, talked about here today?
I think so. I'm chair of the admissions committee at NYU. Let me just tell you that the students who come, the applicants who come in, we interview everybody that gets accepted. A personal interview at the school. And I can just tell you that the applicant pool is just phenomenal. The decisions are very difficult, because if you look at as you said, overall GPA, science GPA, DAT scores, their essays, the quality of their interview, and then I have to tell you, they come in. This group comes in. They are dressed impeccably. Men and women are just really wanting to make an impression, and it's amazing. So yes, we're going through a period here where if you're going to get into dental school, you have to do well in college.
Yeah.
Yes.
It's an interesting question. I mean, I'm curious, Dr. Nasseh, what do you think about this topic? I mean, I know this is more of an admissions type of conversation, but I guess it has to do with the quality of applicants that go into the postdoc programs, into the workforce. Talked about that number 7,000. What is your take on all this?
Well, I mean, there is, as Rick also said, as the population is increasing, as we're opening up more to the global market, the sheer number of applicants are going to go higher, and therefore competition is going to get greater. So the more the competition, you're going to get generally a better cream of the crop. You could also make an argument that there might be some great inflation going on.
That's right.
Because that is certainly something that is out there as well. But that's I guess is for the better. I guess in many ways, that's why if there's more competition, the better, which will improve the quality of care, the quality of dentists.
Let me chime in here, if I may, also, because yes, obviously through the years, and what I was telling them, Rick, before we started the podcast, I don't think only a Parsa had ever heard the term "gentleman C." And I was talking about in the 50s and 60s, C was a very good grade. And then through the years, they obviously great inflation has occurred. And as I mentioned, Ollie and Parsa before, now you have JUCOs, all kinds of preparatory courses for things. Thank God for standardized tests. So I think it's very, very difficult comparing a B at schools A or school B and C, then comparing it from the 60s to the 70s. That's difficult. But one of the things that Dr. Valachovic mentioned that I think is a very, very key thing, and I mention this to anybody who wants to get into the endodontic program because they're not in the match. Rick mentioned everybody has a personal interview. And I think when you're a person who's looking for dentistry as a career or medicine as a career, actually anything, I think having a personal interview is a huge separator. And, it's really funny, Rick, when I was at Harvard, there's multiple people you have to go through. And having spent many years in Asia, 10 years in Asia, I was always kind of a warm-up for many Asian applicants because they would relax with me. And, because it's intimidating when you go into a school and a series of interviews, and I would be able generally to relax them. But I think, Rick, for me, I think a personal interview is a big deal.
And, when I was at ADIA, we did a really comprehensive survey of advanced education programs, Rick. And when we were asking what is it that you really want in your the applicants and then the people who are going to join your program. And, there's this perception out there in many ways that, we need the person who is graduating at the top of their class, that has the highest GPA from dental school and so on. But yet when you ask, what is a successful resident or postdoc in your program? And it's, a commitment, right? An ability to be part of a team, a willingness during the time that they're there to to collaborate with others, to be available for emergencies when needed, right? Being a very bright person isn't necessarily what is most
Right.
desired.
Right.
But yet we keep saying, oh, I want to get either you're number 1 or 2 in your class, or you're not going to.
Right.
Well, but then you get people who can take tests well,
Yes.
aren't necessarily
1000%.
contributors to
Right.
the program.
Right.
And so we've got to get away from this concept that just having a high GPA
Right.
is gonna. And so that's why, again, as you said, in personal interviews, so
And Parsa, what I used to do, and Ali, I think you remember how I used to do this. I would get to the point of all the application pool. I would personally meet 15 to 20 people, right? But when I started doing interviews, it was like playoffs in a professional sport. Everybody started equal. Okay. So whether you were the first person I wanted to make sure I asked, or the last one who kind of snuck under the wire, all that was off. Everything was about you as an individual, selling me why I needed to take you into the program. And I think that's a very good way of doing it, because what happens, as Rick said, almost always is never based on academic performance. There's other things that, and what's crazy, and I don't mean to scare you, Parsa, as a young person, many times it's the first 3 minutes.
yes.
And what I used to do, the secret be known now, because it was a small program in endodontics with 4 people, I used to use a concept, Rick, that's actually Japanese. It's called wa. Wa in Japanese means harmony. So I would always concentrate on the first person who I always thought would be the first person. Number 2 was the person who could work with number 1. Number 3 was the person who could work with 1 and 2. And 4 was a person. And what was crazy, you understand, for people who don't know, but the dental school is part of the medical school at Harvard. I had people from the medical school asking me, how did you pick your residents? They're like attached at the hip. But it makes for a much more, there's always an exception, Dr. Nasseh, but it was really a wonderful way, because what you had is you had synchronicity, you had a uniform approach. And I think that's really, it works really well, that technique, with a smaller group.
So, Rick, let me ask you this, because I've had this idea for a while, and I think it kind of comes down to the crux of what we're discussing here. And you, as the director of the admissions there at NYU, which is the largest dental school in the country, I feel like the real question here is, what are the standards for what makes the best dental student and consequently the best dentist? And I think these are the problems when it ends up being a part of the interview, ends up having the bias and so on. But I feel like if these criteria could be boiled down to specific values that could have weighted, then it could easily be programmed into an AI program in which the role of bias would then be entirely removed. And clearly, an interview with a human could certainly be included in there, but maybe that could also be weighted a certain amount based on that. Because I feel like what we want in a student is not just someone who's book smart, but somebody who's also wise, can make good decisions, has the ability to work with a team, and at the end of the day also has the hand skills, which is the part that is entirely missed in the whole admissions process. So what do you think about the potential role of AI in replacing some of the admission bias?
Well, let me tell you about how we do the admissions process at NYU now, that is, I think, ready to be integrated into an AI kind of approach. So there's a platform out there called Kira Talent, K-I-R-A Talent. So when the student, the applicant submits the final application to us, which is usually in June or July, we offer them, require them to be interviewed through this platform. That is that, they, within 2 weeks, they have to be prepared to have this interview, which is virtual. We ask the questions, and the applicant responds, usually like a 2-minute kind of response. And then their responses are graded by trained evaluators, 2 of them, about their responses. And the questions relate to the things that you just talked about: grit, leadership, ability to interact with others, communication skills, nothing really related to their cognitive skills, but really related
Empathy,
to
right?
all of the other things.
Yeah.
Yeah, empathy is one of them as well. And so then they get a score based on that, from 0 to 4. And we use that as one of the other profiles that we use to select from. So that can easily be put into an AI system that puts all of that together. But again, really, yes, we want to have people that have that can handle the rigor of a dental curriculum that within 4 years we need to produce an independent practitioner, right? And compare what our curriculum was, compared to what students have to do in dental school now within 4 years. And so, often we hear from dentists of our generation and saying, these students just aren't prepared when they come out. Well, when you think of everything, implants and periodontal disease care, period care, endodontic care, robotics, everything that there's expected of them now. Besides the science, I mean, and there were whatever, maybe 2,000 drugs in the formulary, 40 years ago. There's now tens of thousands of them in the formulary, and changing every day. So I think that yes, we need to have people that can handle all of that, the rigor, but also have all the grit, the empathy, the leadership, the collaboration as well.
I have a question for you, Rick. There was a point a number of years ago where there was some serious discussion, at least to an outsider, it seemed like a serious conversation about should dental school actually be 5 years and having the fifth year as kind of almost like a GPR. Has there been any thoughts about that, or was that a program that was going to be based totally on federal funding, and federal funding is becoming a nightmare? So, where is that? Is there a feeling that maybe dental school should be a fifth year, a non-tuition based fifth year?
I mean, as you said, it was a trend for a while, and
Yes.
it really has gone away.
Right.
It
Right.
really, and what's interesting is, earlier, I hate to keep going back to our generation, but almost everybody went into the military,
Right.
right, and had a 2-year experience,
Yes.
caring for healthy, mostly men, right?
Yes. Yeah. Healthy young men,
and
great patients. Right.
and great patients,
Right.
right? And you could really gain your skills and
Yep.
come out. So I think that we're the fifth year in New York. You have to have in order to get licensed.
GPR. Yes.
You have to have some postdoc education. But the problem here has been that that's reduced the number of first-time applicants for licensure.
Right.
Because right, if you haven't done it, you can't quite. So I think all of those issues are going to continue to grow, but it's a way to go.
I'm going to ask Parsa a question now. Now, Parsa, as a dental student, do you have enough time in the day to do what you want to do in terms of dental requirements? Outside activities, I'm not talking about, right? But in terms of what's needed, in terms of what you think you need to do, the time you need to spend with your dental demands from school, do you have enough time in a day, or how does that work out? How do you parse the time?
Yeah, it's a good question. It's something that I was thinking about bringing up today with Dr. Valachovic here. A lot of people in dental school, they're medical school friends. We spend a lot of time together, and you think about the trajectory of those 4 years and how the requirements are set up from a national perspective and a school perspective, individually. And I think the schools that are not set up in a pass-fail system really, really put a lot of pressure on the students. I went to a dental school that was not pass-fail, and I absolutely loved it. I learned a lot. I felt very clinically competent, but there were times where you really think about your next 2 weeks and you look at the schedule of exams and summative clinical requirements. And for those listening who are trying to get into this to dental school, I think time management is so important, and it became
Yeah.
stressful. It
Yes.
really was. And I
Yeah.
think that were those were the moments, those stretches of 1, 2, 3 months where things were so chaotic, where you separate the wheat from the chaff. And perhaps the people that knew how to separate and manage their time, are you able to study? Are you able to prepare clinically? Are you able to prepare for your patients? Are you able to pursue your own personal social agendas? I mean, these are things that are important. And then you look at our medical school friends, and obviously such a hard curriculum, but the pass fail system that they've universally adopted is interesting, because you focus on learning, you focus on, the grade doesn't matter as much as the actual takeaway of the information. And I think adopting that nationally could be a huge shift in the system of how dental school works, and probably for performance of clinical competence. We talked about that. It's not just about the test scores. And, Dr. Nasseh, we've spoken about this, Dr. Koch. How do you evaluate candidates? It has to be more well-rounded. And, this is a question I have for Dr. Valachovic, because the audience really wants to know this. What are the secrets to get into dental school?
At least to NYU.
Yeah.
Yeah. Well, I think, during my time at Avia, I went to every dental school in the United States and Canada and foreign as well. I think that the secret of getting into it is really, first of all, be successful at your college academic program, the grades. But I then identify 2 or 3 things that help to differentiate you from everybody else. Be a leader in a club, be a leader in a sport, perhaps. But what is it that makes you different than the others? And I think that what I would focus on are differentiators, things that you did and pursued and made clear that you had the commitment and that there was a success at the end. Now, that success may be, we tried this and it didn't work, but that was a success because you tried it, even though it didn't. You learned from it.
Mm-hmm.
So I think that being successful in your college, being able to do some outside activities that show your commitment, and particularly leadership, to also have the exposure that gives you something that's just that little bit different. And so something in the community becomes very important. And I think the DAT is important, but yet we know that it's not as likely to show success beyond the first year of dental school, right? So I think you need to be able to show that you can handle the rigor of a scientific program, that you can show a commitment and some leadership, community activity, and those are the kind of being prepared for the interview, spending the time to put together an essay that doesn't look like it's AI generated, that it is very, I think that's a killer.
Yeah.
People who have, something that is clearly AI generated, and don't, your application will be set aside.
Wow.
So those are the kinds
Powerful
of
words.
And
yeah.
Parsa, let me add a couple of things to you also. I think one of the things for prospective students is try to get to know something about the school. Maybe make a visit. See if there's a couple of people that you can speak to, okay?
Mm-hmm.
That adds an enormous amount, because what happens a lot of times with young people, when you're going for interviews, whether it's college or professional school, they want to be kind of cool and composed. As Rick will tell you, and I will tell you, enthusiasm goes longer than you guys realize. Like, I really want to come here. It's big, and you don't overdo it. But if you know a little bit about the school beforehand, if you've spoken to some of the students who are at that institution, you go in with a lot more confidence about having a conversation.
And to follow that up, I think, many people have personalities that are more introverted and so on, and be prepared to come in, and you need to be able to define yourself beyond your application. And the interview really is usually very critical. And showing enthusiasm and getting out, all right. So if you are an introvert, then that means that you need to think about what you're going to say before you go in. Well, you can find out what the kinds of questions are in general that are going to be asked. ADIA has these Go Dental events, both at the annual session every year, this year outside of Washington, D.C. and beyond. Many of the dental schools have recruitment programs that come around. Just do anything that you can to gain more knowledge, to put yourself in a better position.
Well, you mentioned, Rick, also about Annie mentioned the potential for adding a fifth year. That kind of leads up to the question, although you mentioned that it may have been tuition free, to the reality that in the US, dental school is 4 years of undergraduate plus 4 years of dental school, and then potentially turning into 5 years. That means 9 years to become a dentist. Aside from the rigorous academic work involved, plus the all of the additional stuff to do, I think to me the greatest structural problem we currently have in our educational system, vis-a-vis now the presence of DSOs and corporate dentistry that is coming in, that is essentially designed for cost cutting, is the reality that dental education costs up to $1 million in terms of student loans and so on for these graduates to leave. And then as they leave, they're facing issues with, student loan payback, insurance companies trying to cut down fees. Now, soon enough, once DSOs gain enough momentum, it's not going to be quite the distribution generally tends to trickle up in these types of large corporate entities. So how do you think, economically speaking, this rising cost of tuition, now with potentially adding more time and so on, will square out for the average practitioners coming out to try to make dentistry something that you would want to recommend to your kids as a profession down the line?
Well, first of all, I think that what we're seeing is that in spite of what we may think from inside, there is this perception out there, and I think appropriate, that dentistry is a very attractive profession compared to other health professions and other opportunities in law or business or anything else. So it is an attractive. But I think that what we need to do is, first of all, within the current structure, do everything that we can to make sure that students come in understanding the costs of the program, and how to get credit, how to get good credit, how to be careful about your spending. You don't need to start the doctor's life in your first year of dental school. That you need to be careful about expenditures, and because you're just going to have to be paying that up. But I think that there's other things that we need to be thinking about. We really need to have 4 years of preparation in college to get to dental school. And then we repeat biochemistry, physiology, anatomy, and so on. Could we go back to, if you have fulfilled the prereqs and have demonstrated your capacity, why not a 3-year, apply after 3 years? You may not get your bachelor's degree, or, programs like NYU, we have a 7-year program from the students that are at the College of Arts and Sciences and then come to the dental school at the end of their 3rd year of college. How else can we reduce the time in seat? So we need to also look at competency-based education, right? We all know that there are students who have completed all of their requirements and are ready to take the board exams by the end of the first semester of their senior year, right? So why, if they're completed, why do we need to make them stay till May when they really could graduate and move on and either take the boards and start practicing, or be better prepared for their advanced education program, instead of making them stay in the seat until they complete. Now, we also know that there's students who are not ready in May of their fourth year, and some of them need to continue to finish things, to gain the skills that they have to have. But I think I actually just wrote a guest editorial in the Journal of General Education. It was published in November of last year. That we if we're going to put out students, graduates who are ready for independent practice, using all the requirements of practice now, it's a full 4-year program, or a couple of schools, of course, had 3 years. But how can we reduce the time so that not only do they not have to potentially pay as much tuition, perhaps, but then they also gain more lifetime earnings. Pasha, you mentioned that about your medical school colleagues. Medical schools, first of all, what are their expenses? Maybe an anatomy lab, a histology lab, but otherwise it's lectures. Then they send the students out to clerkships in hospitals, and you can't do anything with an MD, right? You have to do 3 years of residency to really learn how to be a physician.
Right.
And that for the most part, yeah. So, the medical students have a certain luxury of being able to spend the time outside of class, and there isn't an expectation that you're going to be ready for independent practice at the end when you get your MD degree.
That is a challenge. I mean, to be honest, speaking of medicine, most of my physician friends, are not recommending their kids to go to medical school.
Exactly. Yeah.
But that also brings up another point about early graduation and late graduation, is that if we actually were to assign the cost to a degree, then as opposed to charging per year or per semester the students, then it would allow these accelerated formats to move forward, for the education to be more efficient. And also, in some ways, to be honest with you, I feel that the advanced standing programs in many schools, where many students are getting degrees abroad with, no college costs and so on, that then come and only do 2 years and get their dental degree, whereas these other students have had to go through 8 years of tuition. It creates a competitive advantage for the advanced standing students graduating, that then makes them more amenable in the market to go into positions in which there's a lower pay, possibly. I'm not generalizing, I'm just saying that it's a potential possibility, just where the incentives are, and that create a change in the dynamics and the balance of the market vis-a-vis the employments between those who've had an 8-year degree versus those who've just gotten the 2-year tuition degree. Do you find that to be a challenge, and do you think potentially a charge per degree could solve not only that problem, but also those who want to graduate early and get out of school sooner by fulfilling the requirements faster?
It's a great point. Yes, I think that is, and that feeds into, if we talk about doing competency-based education, that as long as you can demonstrate that you have these skills, and that you can move on, as opposed to making everybody go through the exact same program. That if an argument that you're going to hear, of course, from the dental schools is, well, what if they leave at the end of the first semester of their fourth year, we lose that tuition? Well, as you said, if you say, here's the price of the degree, and even set it at the beginning of, if you're coming in, here's the tuition you're going to be charged for the next whatever until you get your degree, and that's the price that I think people can then prepare financially for it, as well as then the dental schools and universities can say, well, fine, we graduated competent dentists, but we also were financially sound in doing it.
Rick,
but you make good points.
That brings me to another point. Does the dental school at NYU have a proactive relationship with Stern, which guys is the business school at NYU?
Not yet. That's one of the things I'm working on. the demand for MBAs in New York City is just so intense
Right.
that they're trying to figure out how to be in a collaborative. But and you make a good point, as I, leaving D after 22 years, if I was asked what is the most compelling issue facing the dental profession, it's leadership. Who's going to follow us, and who's got the financial and business skills
Right.
to be able to run these
Right.
big DSOs and large.
Right.
Now we know that many of the DSOs have still have founding leaders
Right.
in there, right? So when those founding leaders move on, either because of just generation changes or that they sold the businesses, who's going to take their place? And we don't have a leadership ladder for dental education, for the military, for the corporate side of dentistry, for organized dentistry. Who's going? Who's going to be? We know the changes that are going on in both the ADA and the specialty associations. Who's going to be the leaders that are going to follow us? And so that's why we're so focused on developing leadership programs here at NYU that are like the programs that many of us experienced at Harvard, where if when I was at Harvard teaching and on the promotions committee, we everybody was going to graduate into and move into some position that would lead them to leadership in the future, right? And I remember we had one student who went directly into private practice. And for a year, we kvetched about how did we fail that student that he thought he could just go in right into private practice. So, but I think that's what and the business acumen, as you talk about with Stern is our business school, or the B school at Harvard. We really need to have a cadre of dentists who have that level of sophistication in finance modeling, the entire side of entrepreneurism to make it work within a dental perspective.
It was really interesting, and I'll take this back to the 70s, early 70s. University of Pennsylvania was very proactive in multiple degrees, and the most proactive school with the dental school was Wharton. And
Yes.
So there were numerous people coming out with a DMD MBA. But the other thing that was really very helpful, if you were running a program in the school and you wanted somebody to come in and speak to your residents or the students about how to learn with obscene debt, okay, they would send somebody over almost immediately. It was incredible. And I know there's some universities where the business school is not so energized to work with the dental school. But I think having a dental school component, working with either the undergraduate students or certainly the residents, how to finance things, how to learn, how to live with your debt, I think it's incredibly helpful.
Yeah.
And Dr. Valachovic, so I think it's a good point, but I have to say, if you think about the cost of tuition, you think about the cost of tuition of dental school and business school, right? So let's just take Harvard for example, or Harvard Business School. These are 6-figure yearly tuitions, and so you have a whole cohort of students, residents that want to do that, but they're thinking, okay, so I have 4 years of dental school, I have maybe 3 or 4 years of residency or 2 years of residency. How am I going to fit in another 2 years, $200,000-300,000 in business school debt, plus opportunity cost of not practicing and making very, very, attractive wages as a practitioner. And so the idea becomes, how can we incorporate that into the 4 years, or how can we get it into the residency programs? But all of that is is okay, and it's understandable. But Dr. Nasseh, you talked about the debt and the wages. I think, to me, the question isn't so much about the time. It's about, how do we lower this tuition? Why has it gotten so high? What can we do to tackle that head on? I mean, we can train people to be management leaders and financial experts as well, but how do we really tackle the problem, which is the actual absolute value of that tuition? How do we lower that?
So I don't think we can lower the tuition so that that it makes all that much difference, right? But you sound like you went to the B school at Harvard.
No, no, I didn't.
Last question.
No, I didn't actually. I've never been to business school.
Is naturally like this.
He's naturally like
No, thank you, I guess.
So I think that what we I don't think we can substantially reduce tuition to a point where it would matter overall. Right. So then we've got to work on the other attributes of what the end debt is. And so can we cut back on the number of years to the degree? For the most part, outside of North America, you graduate from dental school after leaving high school, right? And then 5 or 6 years after you graduated from high school, you're able to practice as a dentist. So how can we cut that? How can we look at competency-based education? How can we do a better job at creating students during their years who have the financial knowledge to handle the debt and to be ready to pay it off? So what we're doing at NYU, we have what we call a Dental Student Leadership Institute. And so we bring in about 35 students each year for a 3-year program and really spend a lot of that time on business education, financial education, that now leads to, this is the first year that we're going to have the 4th-year students. And on actually Tuesday of next week, they'll be presenting in a Shark Tank format.
Oh, nice.
Presenting, so a couple of them are creating new apps for dentistry. Another one's creating a new dental school. Another one is creating a new delivery model that would combine dentistry, optometry, and ENT into a new business model. So we're preparing this group of students, at least, to have the financial acumen, the business acumen, to be able to carry that forward. But it's all about developing leaders for the future. But yeah, I just don't think that there's a way to substantially reduce tuition. What would we give up to be able to do that, given everything that needs to have to prepare students for private practice?
Rick, at the medical school, your medical school there at NYU, the tuition has been kind of way for a little while, right? Based on a big grant.
About 5 years now. Yeah. They got a major grant that allows there's no tuition at the medical school. So if you can find somebody who's willing to, if we could find somebody who's willing to commit $1 billion, we'd be able to make that happen. But Mayor Bloomberg has done the same thing at the Johns Hopkins School of Public Health. So again, it's another conceptually, it's another way if we can get philanthropy to be more a part of the work that we're trying to do.
Rick, this comes from a perspective of total ignorance on my behalf, but have any of the DSOs developed relationships with dental schools?
Yes. As an example, the new dental school in North Carolina, High Point University, received.
Where's that going to be?
In High Point University. Okay. All right, and so Rick Workman.
Yes,
founder of Heartland, gave I think $32 million, and as part of it, trying to establish a new dental school that better prepares students for DSO experience. And there's other, but that would be the most dramatic. Somebody who gave a substantial gift to a private institution. I don't know eventually how that will impact tuition overall. They just started with the first class, but those are the kinds of things to see for the future as well.
Do you foresee more corporate involvement with dental schools? And I know, and I think Parsa and Ollie as well, is that when you go overseas, many dental schools have pretty close tie-ins with different corporations. Do you see that becoming an increasing trend in North America?
Annie, I think that overall within the health professions and hospitals you remember maybe 5-6 years ago, there was this real concern about conflicts of interest.
Yes.
And so, I mean, we even, the bags that we had at the annual session, we had to put the sponsor on duct tape, kind of equivalent, so that when they went back home, they could pull the sponsor
Off the bag.
label off of the bag, because if they came back with the sponsor on, they would get into trouble. So I think that the pendulum is swinging. Hopefully it's coming back. Hopefully it's coming back.
I think corporatization is it seems to be inevitable, not just in dentistry and medicine, but I guess across the board in our system. Rick, but I think this kind of plays also along with the idea of tuition, cost, education, as well as access to care, right? I mean, we know that access to care is not distributed equally. It's not homogeneous, very heterogeneous, at least in this country. And you see concentration. So as we were talking about the number of dentists, it is true that maybe the numbers have not, whether they have gone up or down, whatever has happened, their distribution is not equal. There are areas where there is great need, and then there's areas where there is excessive competition. So that sometimes goes along with the fact that if you are putting in 8-9 years, or in our case with the specialty add to that, that's like another 11 years in total, with having gotten tuition and loans and costs, you don't tend to want to go to a rural area where there's a lot of need. And so there's a concentration of people in high cultural places. So you get competition in the cities and not enough in rural areas. So don't you think that's the structural problem I'm talking about, is that unless we can address the tuition cost and also maybe find a way to get around maybe paying back some of the loans so that we can send people to where there is need. Yeah. What do you think would, I mean, as you mentioned, military was one option. What other options do you see to address this issue of unequal care?
Okay, so there's this joke in New York: if one more prosthodontist opens in Manhattan, the island will sink. Right? If you look at Utah, which opened the 2 dental schools, all of the dentists really are in that Salt Lake City, Provo, the Valley, right? But otherwise, Utah is a dental desert. So I think that in my experience, there are many people who have rural practices that are doing very, very well. It's not like you need to be in the city to be successful. There are rural practices that are doing. I mean, and I know of 2 specifically, one in Oklahoma and one in Texas, that have their own landing strip for their private plane adjacent to their practice, so that they can get to another airport now. Anyway, I think that what we're seeing is that a lot of there are a lot of opportunities for companies and especially foundations in many states now that are looking at ways to do loan forgiveness for if you work in an area that has an access to care issue. But I think that we just have to provide students with really a better understanding of the options that are out there. Many of them think that they can just open up or go into a practice in an area, as you said, that's urban and culturally advantaged. But I just think that we've got to find ways to incentivize graduates to go into these rural areas or into areas of cities that are dental deserts as well. There certainly is that in all the major cities. But we're looking to foundations. We're looking to others. A couple of the DSOs are focused only on rural areas because there are opportunities there as well. But it's a compelling issue. That often I'm asked, do we have enough dental graduates? Do we have too many graduates? Well, we have enough graduates to take care of the population that can pay for it, that has the health literacy to understand what the role of dental care and oral health is. But there's a load of people out there. And now if we're starting to pull fluoride out of water supplies, you know, when I started as a resident at Children's Hospital of Boston, the water supply in metropolitan Boston was not fluoridated. The Christian Science Church had been able to prevent that from happening. And I just did quadrant dentistry all day long on the patients that we had from the local area. And then once it was fluoridated in the early 80s, when I was then on the faculty, we had trouble, and the fluoride was in the water. We had trouble finding lesions for students to practice on. So I think that if we pulled fluoride out of the water, as seems to be happening in Florida, and now statewide, the bill is on the governor's desk to pull Utah, that we're gonna see go back to erupting first molar permanent molars that are going to need endodontic treatment or extraction. That the level of caries, both in the primary dentition as well as the permanent dentition, is going to skyrocket again. It's really a very scary time, and I think it's going to really impact the future of the practice of dentistry.
Let me ask a question about that, not necessarily from the pure political angle of that, but in terms of the resistance to pulling fluoride. Where is that resistance coming from? Is that coming from only the dental schools? Is there a state administration in each individual state? Their level of pushback may vary from 0 to 100, but where is that discussion actually taking place on the ground?
So the ADA has been very public about it. And I was just interviewed 2 days ago by the Wall Street Journal about it. I think that we have gone for 75 years with fluoridation, and it was just 75% of Americans benefit from community water fluoridation. And it was just well, it's just accepted. What happened? Almost overnight, this political intervention that is pushing on it. I just wrote a blog post that went up yesterday about how do we deal with the vaccine hesitation issues now. I think that we haven't done a good job, Annie, as public health people.
Right.
Of countering these kinds of things, that we just assume that evidence is enough, and it's not.
Right.
With all of the different kinds of information that's out there, we need to worry about.
On a much, much lower scale, Ali and I have faced that as endodontists with focal infection. Actually, Ali, I think you have a couple of videos on your YouTube site addressing that stuff, right?
Yeah, I mean, just the explosion of information through internet and social media in the past 15 years is basically what Martin Gorey in his book Revolt of the Public kind of predicted, is that misinformation and malinformation, all this stuff is on the rise. So we just have to be more cognizant. And you're absolutely right that fear mongering works far more effectively than rational evidence. So it requires people to kind of go out there and advocate properly for these things that are important. But Parsa, what do you think?
Well, no, it's a sort of, you guys touched on it, but I did read that piece, Rick, regarding sort of the vaccines, and I think you referenced the former FDA commissioner, Dr. Scott Gottlieb, who does such a great job, Jerome Adams, the former Surgeon General.
Yeah.
But you spoke about the spawn of polio and measles after decades of it being so quiescent. I think this is a tough conversation, a tough topic, but some of these things like vaccine mandates, fluoridation in the last couple of months have become kind of political. And so then there's a question of science, medicine versus politics. And I guess a question I have for you, given all of your decades of experience dealing with this, the politics versus the medicine, how much of an influence should politics have? And I'd love to hear everybody's answers in this healthcare decision-making process. Is there a good spot for it? And I say that because some people argue that there's a duty for experts to engage in this political discourse, to inform people, to correct the misinformation you're talking about, Dr. Nasseh. And some say that you should stay neutral so that you can retain that credibility as an independent source of information. How do you see all of this playing out?
Well, from my perspective, it's what is the politics meant to do? Sort of in the past, the politics was to provide the evidence, the regulation to ensure the safety, do whatever we could to ensure the public health of the country. So, but that has now, the politics is more of how do we move back to this perception that independently minded is more important than what the evidence might say. So the politics used to be what is the best thing for society, and now it's not necessarily the best thing for society. It's what might be perceived as the best thing for the individual, and within that political realm is the concept that, well, whatever, it doesn't matter what the science says. I want to do what I want to do, and so vaccine hesitation, fluoride hesitation, all of these kinds of things and they're going to matter. I mean, we need to follow what's going on with this measles outbreak in Texas, and it's being perceived. Well, it's people weren't vaccinated and children die. Well, that's the natural course of things. No, it's not the natural course of things. And those of us who grew up seeing classmates who had polio and who were on crutches all day, I never saw anybody in an iron lung, but I certainly knew families that had their children in iron lungs. It's a very, very, very scary time, and to walk away from the WHO in the way that we have is scary. America needs to be a leader in the public health space. Annie, what do you think?
I agree with you. And I think one of the things, and this gets into a lot of different things, and Parsa, you have to remember, Rick and I are from the generation, we had civil defense drills for nuclear reactions where we would hide under the desk. That's what the drill was. I'm seriously, you would go under the desk.
When you see a flash duck, right? Duck and cover.
So
That's scary.
I'll be amalgamated with the wood from the desktop and the metal legs, right? So there's a couple of things here. One of the things to me, and I see this also not just in terms of politics, but with the influx of new technology. And where I'm going to this is, you guys have, Ali, you heard me this at a number of dinners at Harvard. It's an honor and it's a privilege to be a healthcare provider. And whether you're a dentist, a nurse, or physicians, do no harm. And I think one of the things here is, like with new technology, okay, it works 8 out of 10 times. But what happens the other 2 times, right? You've got to make a cost benefit analysis there. In terms of politics, I think, again, as a healthcare provider, you have to be able to separate yourself. One of the things I've always said, Parsa, to people is, this is a real provider. You treat the person who just came out of prison the same way you treat the CEO of a company on 128. Okay, if you're able to treat those individuals in the same manner of compassion, you're a healthcare provider. But if you're obviously prejudiced against one or the other of those people, that doesn't meet what I consider to be a true healthcare provider. So I think what Rick's talking about is also the same thing with me, as you have people involved in, as they say in patent law, in the art. Okay, if you're a clinician, this is dentistry and medicine, and you know what's real, I think it's incumbent upon you to share that evidence. I think it's also, I have no problem, Rick, there's so much fudged research, right? There's a lot of research that I don't use the term generally, but managed, let's say managed, okay? Managed research. And you have to sometimes be able to call that as it is, like, well, maybe there's some discrepancies here, right? But I do think it's part of the honor that you take as a healthcare provider, Rick, to state what you think are the facts and the science And we've all heard it, follow the science. And I strongly believe in that.
What do you think, Dr. Nasseh?
So, from my point is, I agree with both of you, of course. But Rick, you being also a pedodontist, you have had formal training at Children's Hospital, so you know that the importance of fluoride, especially for younger population, in terms of caries prevention and so on. But as you said, it's been in the water for 75 years. What do you say to those people who say that there are now alternatives, such as, external fluoride for a at-risk population, as opposed to mass fluoridation of everyone, so that we could be more targeted to the people at risk, as opposed to give it to everyone, even though the parts per billion level that we have in water is entirely safe. The kind of the semblance of safety and so on seems to be everyone's on the edge, the modern age. So what do you think about more targeted versus mass community fluoridation?
Well, it's really very consistent with all the other issues around access to care. When we talk about targeted, we're talking about targeted to families that have an understanding of the role of fluoride, of the role of oral care, of the role of regular toothbrushing, and flossing and so on. That's a limited population. The value of community water fluoridation is that everybody gets access to it, no matter what. And you don't have to go out. People have to make choices about buying toothpaste or about buying new toothbrushes, about buying floss, about going to the dentist. I mean, those all of the kinds of things that we think about in targeted approaches. But it really is an overall access to care issue in a way that having community water fluoridation, everybody in the community gets access to. And, you can target the other way as well. You don't want fluoridated water. Fine. I mean, there's bottled water. There's filters to take fluoride out of water. Especially people who may be pregnant or considering pregnancy. There are those filters there that can remove it. But otherwise, everybody benefits from this constant washing of fluoridated water over their teeth. That helps to prevent demineralization, provides for opportunities for remineralization, and in fact, it interrupts some of the bacterial enzymes in the plaque that produce the acid.
Yeah, I mean, we all learned about fluoroapatite being so much better than hydroxyapatite and stronger.
Exactly.
But it's interesting because I feel like there is a spirit in the conversation, and that's the spirit of, the individuals who don't want it in their water versus those who really need it in the water. It's kind of the same argument as vaccination, right? It's kind of, we're talking about choice, individual choice, but at the same time, it's individual versus the community. It's a fascinating conversation and topic. I guess this is more on the ethics and
Well, one of the things that also factors into this conversation, Ali, is that the other thing that we have in our armamentarium against caries, of course, are dental sealants. But if you really look at dental sealants, there's a huge economic disparity. Okay. And so, wait a second here, that group that doesn't have the economic means of the awareness for dental sealants, they're basically depending upon, as Rick said, fluoride.
It's interesting. I guess one of the last things I'll ask here, Dr. Valachovic, is regarding the future of our dental education system. I mean, there's been a lot of changes probably over your decades of experience.
Right.
What can you tell us, and what can you tell the audience who's really interested to maybe play the game of predictions? What will happen in dental education that has never happened before in the next 10, 20, 30 years that we wouldn't expect?
Well, I think that everything that we could do, predictions of the unknown, are relate to technology. And we just seen what's happened in AI in just the last 2 years. I just think that we can't predict what the role of AI is going to be in providing care in the future, putting all this digital dentistry together, being able to provide care, particularly on the diagnostic side, as well as the treatment side. But that's where dental education has to be prepared. And I'm not sure if we're ready for that. I think we're still stuck with just introducing the individual components of new digital technology. I think but what is encouraging to me certainly is that this new generation is coming out of college and coming to dental school with a better appreciation of the role that AI and whatever other consequences of AI and digitalization. I think that what it's going to mean also is that much more of dental academic experiences are going to be in the community. I think that we're going to have many more opportunities to work with FQHCs, other delivery models, private practices, where students really gain an appreciation earlier on of what it's like to be in a private practice or a community-based practice, or serving the needs of the community and being part of that. And so, but predicting is always difficult, but I think it's all going to be related to what happens with AI and digitalization of diagnosis and care.
And Parsa, let me just add something on top of what Rick, because I totally agree with what Rick says. One thing I totally feel, and I've always felt this way, every generation is bigger, brighter, smarter, faster. And the place you see that is obviously in the world of sports, records. When Rick and I were a bit younger, 4-minute mile was unheard of. And now you've got junior high school kids doing it. So again, every generation. So this gives you something up from the person sitting across from you today. Every generation is bigger, brighter, quicker, faster, smarter. But one of the things I also think, and it's a real concern for me, is the cost of dental education and the cost of running dental schools. And I think as a sequela of that challenge, I think are going to see more corporate involvement with corporations in dental schools going forward. I think some dental schools have to get away a little bit from this, like the sanctity of like, well, we don't want to be too corporate. Yes, there's a part where you don't want to be overly corporate. But I think if you look at some of the models in some of the other countries around the world, and I think with all this technology coming through, I think you're going to see a little bit more corporate involvement, Rick, I think, with dental schools.
I agree. And we've always talked about this delay between what might come out of a research lab or out of a corporate research laboratory. That delay can't continue to go on. As you just said, it has to be better and faster.
Right.
And much of what's going to be coming out from a delivery perspective that's going to impact patient care is going to come out of the corporate world, not out of whatever IHN, IDCR, or other. And so I totally agree with you that the collaboration, the pendulum swings always, right? Mm-hmm. And I think that the pendulum is going to swing back to, we need to work with the corporates to get these new techniques, new procedures, new products out much quicker than
without question.
Boy, that ADEC meeting in Dubai, it was amazing. $1 billion worth of transactions that occurred.
Wow.
There's just so much new technology and new opportunities. Unbelievable.
Well, Rick, this has been tremendous. This has been so thoroughly enjoyable for me, and it's kind of nice to have someone, Parsa and Ali, from my generation, where we can share things. And as you both are probably kind of stunned, Rick and I can talk. We like to use the term communicate, Parsa, right? That's a nice term. But Rick, thank you so much for joining us. For myself personally, this has been absolutely wonderful opportunities catching up with you.
All right. I enjoyed it as well. Thanks to all of you.
Yeah, thank you, Rick, so much for joining us. And Parsa.
All
right. Dr. Valachovic, thank you so much. It was an excellent episode, and we hope to have you back soon, sir.
Yeah. Have a great weekend. Thank you.
Bye-bye.
Now, for you guys, make sure you write down below what you thought and what are some of your perspectives about the education, the future, and any of your questions. See you in the next video.
Okay.
Cool. Yep.
Ollie's got the spark with the brightest smile. Annie's wisdom spins facts in style. Parsa dives deep with a touch of flair. 3 generations of dental care. Root canals and life beyond the chair. Culture and politics we dare to share. From molars to moments that shape our day, we drill down deep in every way, turning pulp into gold with every word.